Hello, this is the first podcast for children with altered respiratory status. And these are the concepts we are going to cover in this lecture. What we need to begin with is that there are several differences physiologically between children and adults, all right? So here we're really getting into the differences. First off, the brain is immature, so it has more difficulty controlling respiratory status, all right? So when we are assessing an infant, we must assess the respirations for 1 full minute, okay? Because they do not breathe in an even pattern. Their airways are smaller, so it's harder to get air in and out. Their chest wall and respiratory muscles are less developed, making it harder for the chest to expand and contract. Lung tissue has fewer alveoli in it, so there's less surface area for gas exchange to take place. All these things mean that the younger the child, the greater the risk of respiratory distress. Here is a picture. You can see the amount of, at 25% of, this would represent swelling. You can see how small an infant and child's airway is compared to what swelling to an adult airway would do. And you can see here the anatomy. Also understand that an adult's larynx is straight, while an infant's is more cone-shaped. This makes it more difficult to perform certain procedures like a bronchoscopy. It also causes increased risk for complications, increased risk for choking. That's why those anticipatory guidance sheets and what's appropriate, what's not for certain ages are very important. We talked about the different shape of the larynx. Larynx are smaller in relation to the body proportionately. Also, infants' epiglottis are harder than adults, okay? Remember, the larynx is cone-shaped. This means they're more likely to have obstructions from objects or mucus. All right, so this is a picture of a Lego that's lodged in the bronchus. So when I ask in class what this is a picture of, many students think it's a quarter. All right, so most students think that this is a quarter in the x-ray that's lodged in there, but it is actually a dime. So that is a dime obstructing the airway. The rule of thumb is an infant and small child should not have anything that can fit into a toilet paper roll holder. So anything that fits in there is a choking hazard, okay? Signs and symptoms of that upper airway obstruction would be mouth breathing, loud snoring, apnea in extreme cases, stridor, drooling. We need to teach parents, guardians about preventative strategies for choking, which would include keeping or keeping small infants, children away from choking hazards, and monitoring them closely when they are eating those things. So things like peanuts, popcorn, hot dogs. Hot dogs should be quartered, just like grapes. Grapes should be quartered as well. Coins. There shouldn't be coins laying around. Remember, we talked about suctioning. Suctioning must be faster than 5 to 10 seconds for a child and infant. All right, so we talked about that the infant and small children have fewer alveoli, so there's less area for gas exchange to take place. Signs and symptoms that there is a problem. So a respiratory distress, respiratory disorder would be fever, that stiff neck and headache, anorexia, vomiting, diarrhea, abdominal pain. So if an infant and small child have issues with respiratory system, they're going to have upset stomachs and GI issues as well. They're just so close in infants and small children. Nasal congestion with discharge, cough, respiratory sounds like grunting, sore throats, retractions. We are going to watch nasal flaring. So remember, babies are obligatory nose breathers until about 3 months of age. So if they're breathing with their mouth open, it's very bad. Just to put this out there, most people do not breathe with their mouth open. So usually, if they are breathing at rest with their mouth open, something's wrong. We're going to look at the different areas and the different retractions, which you have a very large handout in your packet about. We're going to listen to grunting and stridor, and those are those respiratory sounds that we talk about. Grunting is actually at the end of an exhalation, and this is when a child is trying to keep their alveoli open. It's actually called auto peeping, so they're trying to keep the pressure on the alveoli to keep them open. Remember that infants and small children may have retractions. They may also tripod, as putting themselves in a tripod position to help get more oxygen. We do not put a baby or small child who is struggling to breathe on their back. That makes it harder. We also do not put them in a high Fowler's. That also makes it harder because we're pushing on their diaphragm and we are actually creating that muscle. We're making it work harder. So we don't want to sit them straight up either. So 30, 45 degrees is a good angle for a child or infant in respiratory distress. So we're going to watch those videos in class. And you do have this as a full page handout in your packet. And these are the areas that we would note retractions, all right? So we have the supraclavicular up here, intercostal, substernal, right here. Suprasternal would be above, and subcostal down here. Now, when you have an infant, you can't really see supraclavicular retractions because they really don't have much of a neck. So what you are going to see is head bobbing. And we will watch a video with head bobbing in it as well in class together, okay? When we are talking about acid-base balance and homeostasis of that, we are going to discuss what our pH should be and what our PaCO2 will be and what our HCO3 will be as well, but understand that, and this is as deep as we're going to get into it, but if the pH balance and something's wrong with the acid-base balance, and it's with the metabolic, so if something's wrong with the kidneys and they're having issues, the respiratory system is going to try to compensate. And if something's going on respiratorily wise, so we have respiratory alkalosis or acidosis, then we are going to, those kidneys, that metabolic component is going to kick in and try to compensate for that. We are not actually going to get into the compensation, the ways that things compensate, but I just want you to be aware that that does occur. As far as the terms you need to know, you need to know hypoxemia, which is low O2 in the blood. We need to know what hypercapnia, hypercarbia is, which is an increase in CO2 in the blood. We need to know what hypoxia is, which is low oxygen in the tissues, right? All those are important terms to know when we're talking about this. All right, so when we are talking about blood gases, normally you would do ABGs. So you're going to do arterial blood gases in adults. For pediatric clients, and the smaller they are, the more likely, we are going to do venous blood gases. All right. So most of the time when we are drawing blood in small children, they are going to draw venous samples. Here are our normals, which you do need to know. Some of them are the same as adults, and some of them are a little bit different, okay, than an adult. The advantages of doing venous sampling instead of arterial is there's going to be less pain. It's only going to be usually one puncture. There's going to be a decrease in cost, and there is a decrease in complications. So for arterial blood gases for small children, there is a high risk for arterial laceration, hematomas, and thrombosis, okay? We are going to do an interpretation paper together in class, all right, to be able to evaluate those, what a blood gas will represent. We'll do that together in class. All right, and you are going to learn more about arterial blood gases when you get to your 151 portion in the LPN program. Or if you have already had it because you're in the RN program, then you should already be more familiar with this. As far as interdisciplinary collaboration, please understand that the most important thing when we're talking about alterations in acid-base balance, we need to correct the primary cause, okay? As far as a nurse, you need to monitor the respiratory status, maintain that airway, maintain a good body temperature, monitor their level of consciousness. Level of consciousness is a good indicator if their conditioning is worsening or improving. Monitor their labs, things like CBC, so we're looking at white blood cell count. We're looking at the H&H to see the carrying capacity of their blood, the red blood cells, to carry that oxygen. We're looking at the CMB or the BMP for sodium and potassium. We're looking at mag, specifically magnesium, because the bronchioles that surround, the muscles that surround those bronchioles are smooth muscles, and magnesium relaxes that. We are monitoring their BUN and their creatinine. As far as other additional team members, we are talking to respiratory therapy physicians, advanced practicing nurses, dietary speech, social work, all those good people. And when we're talking about monitoring eyes and nose, especially with infants, and smaller children, we are talking about weighing their diapers and things like that, okay? There are different types of respiratory failure. Respiratory insufficiency, you can see there, that's where we're able to maintain our respiratory status, but it's hard to do, okay? Respiratory failure is where you cannot maintain an adequate oxygenation, so we're retaining that CO2, all right? And then apnea is the cessation of all breathing. All right, so we may need to resort to artificial airways and mechanical ventilation in cases of apnea. So in this slide it says respiratory illness requires immediate and aggressive interventions. It requires immediate and aggressive interventions because children have less alveoli, have smaller airway, and have less developed muscles. Remember, we talked about that. We need to make sure we're maintaining a patent airway. We're giving oxygen therapy as needed. Medications, we're going to talk about bronchodilators, steroids to help reduce inflammation, hypertonic saline to help thin out secretions. We're going to talk about all these. Airway clearance techniques like suctioning, but we're going to talk about other ones as well. Artificial airways, mechanical ventilation, and tracheostomies, all right? Respiratory distress is more emergent for small children, all right? So this is when you have a respiratory issue, it's more emergent situation. I want you to understand that oxygen is usually administered at lower levels for children. Too much, too long can lead to fibrosis in the lung tissue. So what we do is we give as much as we need to acutely, but after the acute phase is over, we use the least amount of oxygen needed to maintain an oxygen saturation of 93% or greater. 93% or greater is our typical standard. You may see different variations based on doctor's orders, all right? Here are different ways of maintaining pulmonary hygiene. We are going to watch some of these in class, okay? We're going to talk about some of these, especially in class, and we're going to watch the videos, okay? The idea of maintaining pulmonary hygiene is to mobilize mucus and loosen it up so that the child can expectorate it. Expectorate basically means hacking it out, not just spitting, but like hacking it out, okay? All right, so let's talk about trachs, artificial airways. Remember we talked about in the orientation slide those tracheostomy ties should be 1 finger breadth in tightness so that they're not too loose, all right? Make sure we remember that. And our trach is our artificial airway. Most of these are changed weekly, but it's based on each patient. We will perform trach care at least once a day, if not more. Suctioning we already discussed. It is essential to teach parents how to maintain this airway, to recognize signs and symptoms of infection and obstruction. I will tell you that if you're having respiratory issues in your child, whether you be the parent, whether you be the nurse who has the child, if you're having possible obstruction issues, no matter what's going on, if there's a respiratory issue, you need to change the trach and make sure it's completely clean and patent. Otherwise, if you call the doctor and the doctor asks, one of the first things they're going to ask besides vital signs are, did you change the trach? So make sure you do that prior to, that's one of your interventions when you are talking about ruling out issues and things like that, okay? Here are some of our pediatrics with trachs, tracheostomies. This little one's on a vent, this one is not. We have to teach to make sure that trach does not get submerged because that is their airway. These are called HMEs, this is as well. That is a way for humidification. These are called passy mirrors, and what they are, they go on the end of the trach if the child is stable enough. This device pushes air back over the vocal cords to allow a trached child to verbalize. All right. All right. Let's stop the video here at inflammation, and we will continue with inflammation in our second podcast.